Good evening, everyone. Welcome once again to another session of Renal Rounds. So this round will continue our series on water, electrolyte, and acid-base disturbances, which is being led very ably by Dr. Ajay Kher. Uh, I don't need to introduce Dr. Ajay Kher to you because he has already given three such webinars which have been immensely popular. Except to say that, as you can see on this slide, his new affiliation to Vishwast Clinic now, and if my translation is correct, the word Vishwast means assured, which actually describes the way Ajay approaches acid-base electrolyte and water disturbances. So I'm sure that his new endeavor be equally successful. So we now look forward to hearing from Ajay, his take on hypernatremia and polyuria. Over to you, Ajay.
Thank you, Dr. Jha, for the introduction. I will talk about hypernatremia and polyuria. We'll talk about the defense that the body has against hypernatremia, etiology of hypernatremia, symptoms of hypernatremia, the evaluation of both polyuria and hypernatremia, and we'll talk a little bit about water deprivation or restriction test, and then finally treatment of hypernatremia. As we go along, I will build on a few of the concepts that we've already talked about in volume water as well as hyponatremia, and we'll build on those as well. Starting with a case. So we have a 80-year-old male with Alzheimer's who is brought in from his home for being drowsy and not responding for the last 1 day. He's also had some diarrhea for the last 3 days. On examination, he's a thin, cachectic gentleman with a blood pressure around 110/60, minimally arousable, and the rest of the exam is normal except that he has some decreased skin turgor as well. And his labs show that his serum sodium is 175 and his creatinine is 1.5. So the question is, what is the main cause of his hypernatremia? Is it the diarrhea? Is it the acute kidney injury? Is it the diabetes insipidus? Is it inability to respond to thirst? So we'll talk about and come back to this case as well. One of the key concepts that we've talked about before as well is that the body regulates osmolarity as well as volume completely separately, and we have to think about it separately as well. So just to go over this again, so osmoregulation, which is the concentration of sodium that is sensed by the body as the plasma osmolarity, is sensed by the hypothalamus osmolarity receptors, and the effectors that are secreted are ADH, and then it revs up thirst as well. The effect is change in the water excretion and the water intake, and the disorders related to osmolarity are hyponatremia and hypernatremia. And so the key thing to remember is that the body senses osmolarity and regulates it through water intake and water excretion. So hyponatremia and hypernatremia are water problems. In contrast, the body senses volume by the effective circulating volume, and it is sensed at the carotid sinus, the afferent arteriole, atria, and then its effectors are renin-angio-aldo, the natriuretic peptides, sympathetics, and the ADH as a last defense is revved up as well. What its effects are, short-term effects are vasoconstriction, but the long-term effects are through urinary sodium excretion or retention. And the disorders that happen are volume depletion or edema, volume overload. And so these are problems of too much sodium in the body, which is then limited to the extracellular compartment and the interstitial compartment or the intravascular compartment. And that is what dictates the volume. And so these are sodium problems, which are volume depletion or edema, volume overload, while hypo and hypernatremia are water problems. So coming back to our defense against hypernatremia. So on the y-axis is the concentration of ADH, and on the x-axis is the plasma osmolarity. So as you can, the red line is what happens to the ADH. So as you can see, if the osmolarity is below 280, ADH is completely shut off or suppressed. There is no production of ADH. And the urine osmolarity is naturally dilute urine in response to that ADH. As osmolarity increases, the ADH increases in a linear fashion with increase in osmolarity. Thirst is a backup mechanism and kicks in a little later at somewhere around 290 to 300 osmolarity. However, it is the main defense against hypernatremia, as is seen in patients with central diabetes insipidus, in whom there is absolutely no ADH, and they may be excreting 10 liters of urine in a day, but because thirst is active, they will take in 10 liters and will not become hypernatremic. So one of the big take-home messages from this talk is that symptomatic hypernatremia will not develop in a conscious patient if they are able to get access to water. Because as long as the thirst is active, they're going to be able to get their hands on water. They're going to drink themselves down to a normal sodium. So symptomatic hypernatremia requires either an infant or an adult who cannot get their hands on water in response to their thirst. So coming back to the patient with Alzheimer's dementia, so the main cause of his hypernatremia is his inability to respond to thirst. So another key concept that I did want to talk about is going to be through this second case. And this is a 60-year-old male with a severe GI bleed and has just been intubated. And the labs show a serum sodium of 140. He is being kept NPO for the endoscopy that he is planned for the next day. And I've put in 4 different kinds of urine that he has excreted. And then the question is, which of these urine outputs would lead to the highest increase in serum sodium? So the first option is a 2-liter urine output with the sodium in the urine being 100 and the potassium 40. A 3-liter urine output with the sodium of 100 and potassium of 40. A 2-liter output with sodium of 20 and potassium of 15. And a 3-liter output with a sodium of 75 and a potassium of 30. And the reason this is a key concept is electrolyte-free water loss. So when we talk about water loss, the osmolarity of the fluid loss is actually, whether it is urine or diarrhea or any other fluid that the body is losing, that does not determine whether it will lead to hypernatremia. What determines whether the person is losing free water is the sodium and potassium concentration of the fluid. And if it is around 140, then you will get volume depletion because of the sodium loss that you're having, but you will not develop hypernatremia because there is no free electrolyte-free water loss. If the sodium and potassium concentration in the fluid that you're losing is low, then free water loss is happening, and you can become hypernatremic if you cannot replace that water by drinking water. Similarly, when we give fluids to a person, the sodium plus potassium concentration, if it is around 140, then you're not giving any free water to that person. So if you have someone who is getting potassium in addition to sodium, you will need to assess whether you're actually giving them free water or not by seeing whether it is close to 140 or whether it is low. If the sodium plus potassium is low, then you are giving some free water to that person. So let's come back to the question. So if you have 2 liters with a sodium of 100 and potassium of 40, the total is 140. So there is actually no free water loss that is happening. So whether it is 2 liters of urine output or 3 liters of urine output in the first 2 options, there is no free water loss that is happening at all. So with the third one, you have 2 liters with the total sodium plus potassium of 35. You divide by 140, and 1/4 is the salt content or sodium plus potassium content. So 3/4 of this volume of urine is free water, so which would be 1.5 liters. In comparison, when you have this fourth one where the sodium plus potassium is 105, so 3/4 is associated with electrolytes and 1/4 would be free water. So out of 3 liters, 0.75. So In all of these, the person who's having a 2-liter output with a sodium of 20 and potassium of 15 will have the highest increase in sodium and hypernatremia if he is not getting any free water replacement. So now let's come to the etiology of hypernatremia and what are the different mechanisms by which hypernatremia happens. As we've discussed before, you can have water loss, but if thirst is active as well as they can get their hands on water, they will not develop hypernatremia. So there has to be a combination of no access to water to develop hypernatremia. The sources of water loss could be insensible water losses like skin and respiratory. They could be GI water losses through diarrhea or vomiting. They could be diabetes insipidus with urinary water losses, central or nephrogenic diabetes insipidus. Hypercalcemia and hypokalemia also limit free water, cause free water loss as well. And then osmotic diuretics as well as non-osmotic diuretics can cause free water losses. Other rare etiologies of hypernatremia include hypothalamic disorders like primary hypodipsia or essential hypernatremia, where the osmoreceptors are insensitive. Very rare etiologies are actually sodium overload, and these are usually infants who have been given a very high sodium load, or there are some traditions in which salt is being rubbed into a newborn and they can absorb some of that and get sodium overloaded and hypernatremic. These symptoms, so we'll switch now to symptoms of hypernatremia. So the symptoms are the same as hyponatremia in that you can have nausea, malaise, headache, lethargy, seizures, and coma. And just like hyponatremia, the dysfunction is due to hyperosmolarity and it is related to cerebral dehydration. The rapidity and degree of hypernatremia is going to determine symptoms. And severe hypernatremia and shrinkage of the brain can lead to intracerebral and subarachnoid hemorrhages. And just to kind of go over with the pictorial, this is from an NEJM paper in 2000. So you start on the left corner with a normal brain and normal osmolarity. And as you become hyperosmolar, you have shrinkage of the brain and there is water loss in this hyperosmolar state. Then the brain adapts. The first of the rapid adaptation is by accumulation of sodium and potassium and chloride. And so the brain recovers some of the volume. And then there is a slow adaptation, which is in relationship to the cells retaining or acquiring organic osmolytes. So they can generate new osmolytes like glutamine, glutamate, as well as inositol, or they can acquire them through transporters. And with this accumulation of organic osmolytes, the brain volume re-equilibrates. So now when the brain has adapted, if at this point we give rapid correction, then what we get is cerebral edema and we can get poor outcomes and have recurrence of those symptoms of seizures and coma due to this cerebral edema. However, if we do a slow correction, then the brain adapts while we are correcting and it comes back to a normal brain with normal osmolarity. So how do we evaluate someone with hypernatremia? So the first thing is, if someone has hypernatremia, you can check a urine osmolarity. In the setting of hypernatremia and hyperosmolarity, the ADH should be secreted by the brain and the kidney should respond to that ADH with a high urine osmolarity, something more than 600. So if the urine osmolarity is above 600 in the setting of hyperosmolarity and hypernatremia, then you know that the ADH and kidney are doing their job and there is no other abnormality related to that. And this person has only had water loss from whatever reason, whether it is GI or urinary or skin respiratory, and was not able to fulfill the intake that he required, and so has developed hypernatremia, and no further workup is needed in this situation. If the urine osmolarity in the setting of hypernatremia is less than 300, what it means is that there is severe diabetes insipidus. And in this situation, you can give ddavp because the person is already hypernatremic and hyperosmolar. You don't need to do any other restriction. And if there is more than 50% response or 50% increase in the urine osmolarity, then this is central diabetes insipidus. If the response is less than 50%, then it is nephrogenic diabetes insipidus. If the urine osmolarity is in the middle range between 300 and 600, then what you need is further evaluation with ddavp. If the response is again more than 50%, then it is likely partial central diabetes insipidus. If the response is less than 50%, it is either partial nephrogenic diabetes insipidus or related to osmotic polyuria, and that will require the workup, as we'll talk, for osmotic polyuria or polyuria workup, and which we'll come to in the next slide. One of the key things to keep in mind before we do this evaluation is to make sure that there is no concurrent volume depletion, because with volume depletion, ADH will be revved up because of volume depletion, and that may alter the urine osmolarity, which would be not related to osmolarity and the body's response to osmolarity, but be related to the volume depletion. So there shouldn't be any volume depletion concurrently, or if it is, first correct that and then do this evaluation. So now coming to polyuria, and how do you evaluate polyuria? So the first thing is that the definition is an arbitrary definition of more than 3 liters a day. And the first thing to evaluate in this is to combine the urine volume and the urine osmolarity and assess how much osmoles are being excreted in a day. So if the osmolarity that is being excreted in a 24 hours is less than 900 milliosms, so 600 to 900 osms is the normal daily intake in a normal diet. So if it is normal solute intake that is coming out in the urine, then it means that this is a water diuresis. And for water diuresis, you would then have to do a water deprivation test and look at the serum sodium to evaluate and see whether this is someone who has diabetes insipidus or primary polydipsia. If the osmolar output or solute output is more than 1,000 milliosms a day, then it means that there is a solute diuresis, and that solute load is what is driving the polyuria. And so then you have to assess the urine sodium, the urine urea, and the urine glucose. And if you take that solute away, the polyuria will resolve. So let's take a case of something like this. So we have a 50-year-old female who's had Crohn's disease and multiple surgeries, and she has a short gut syndrome. She's failing to thrive at home, and so she's been admitted. She started on a total parenteral nutrition, and 4 days later, she starts developing polyuria with 4 to 5 liters per day output. Due to her blood pressure being 80 over 40, IV fluid replacement is started, and it is with normal saline, and they're matching her output. And next day, her urine output is now increased to 500 ml per hour. So how would you evaluate this patient for polyuria? As we just went over, so we start with the urine volume, which is 8 liters, and urine osmolarity, which is 350 milliosms per kg. So the total osmolarity that is being excreted is 2,800 milliosms. So that tells you that this is a solute diuresis. And when you assess the urine sodium and the urine urea, you find that the urine sodium is 100 milliequivalents per liter. And so that out of the 350 milliosms, 100 sodium plus 100 negative charged anions that will go along with it. So 200 of the 350 osms are due to the sodium, and the remainder predominantly are due to the urea. And so what this means is that this person has a solute diuresis, predominantly sodium, but also with urea. And as you stop the IV fluids and decrease the amount of protein that this person is getting in the total parenteral nutrition, the urine output normalized and the polyuria subsided. So now let's talk about the water deprivation test that you would need to do if someone had water diuresis in relationship to polyuria, or whether you were evaluating someone for hypernatremia and needed a water deprivation test as well. So how to go about doing it? So the first thing is you need a monitored room, especially if you're also considering someone may have primary polydipsia, and you will need to have complete control and no source of water in the room. because many patients with primary polydipsia will find weird and strange ways of getting water into their body, which may include the toilet, wash basins, or any other source of water that is in there. So, and you will have to have complete water restriction. Then you monitor their urine volume as well as urine osmolarity and weight every hour. And you're going to have to ask the person to empty their bladder every hour, because this will be, you don't want them to retain urine in their bladder, because that will affect the osmolarity. The retained urine will affect the osmolarity that you're measuring as well. And then you measure the serum sodium and osmolarity every 2 hours. You continue this till either the urine osmolarity plateaus on repeat checks over the next hour, and there is less than 30 milliosms difference between the 2 hour, or the plasma osmolarity reaches more than 295. At that point, you give ddavp, which can be either 10 microgram nasal spray or 1 to 2 microgram sub-Q or IV. During this water deprivation test, you want to make sure that the weight loss is not more than 3 to 5% of their weight, or 1 to 2.5 kgs of weight. And then this is kind of the curve that you're going to draw from the values that you get. On the y-axis is the urine osmolarity, or the urine specific gravity, and on the x-axis is plasma osmolarity. And if you see, for someone with complete diabetes insipidus, whether it is central or nephrogenic, as you water deprive them or water restrict them, the serum osmolarity will increase, but the urine osmolarity will not increase. And then once you hit 295 and then you give ddavp, those with central diabetes insipidus will respond to this with at least a 50% increase in urine osmolarity, which is shown here. And those with complete nephrogenic diabetes insipidus will not respond. In comparison, those who are normal will have a steady rise in their urine osmolarity as the plasma osmolarity increases, and will get at least above 600 or usually above 800 milliosms when they get water restricted. In the middle will be the group of partial central diabetes insipidus, partial nephrogenic diabetes insipidus, and those with primary polydipsia. And the reason primary polydipsia will not behave like a normal is because their chronic water loading causes a suppression of ADH as well as downregulation of the ADH receptors in the tubules. And because of that, they behave like partial nephrogenic diabetes insipidus. And in addition, because of this polyuria that they have had, they've also washed out the loop gradient. And so the loop gradient does not go all the way up to 1200 milliosms, which it should in a normal person. So the patients with primary polydipsia may behave like partial nephrogenic diabetes insipidus because of those two factors. Both of them will not respond to the ADH or ddavp that you give, and those with partial central diabetes insipidus will respond. However, sometimes the water deprivation test may be equivocal. And the other thing that might help you differentiating between partial central diabetes insipidus as well as partial nephrogenic diabetes insipidus is the level of urine osmolarity. Most partial central diabetes insipidus will get around isoosmolar with the ddavp, or even without ddavp will get at least around 300, while partial nephrogenic diabetes insipidus even with ddavp will not get to around 300. If at any point or in a patient you're not sure whether they have partial central diabetes insipidus or primary polydipsia, it would be better to err on the side of treating them and then reassessing it over time to see whether they have primary polydipsia or partial central diabetes insipidus. Another point of note is pregnancy. So in pregnancy, the placenta makes a vasopressinase, and in some it may cause polyuria. And if you just give them plain vasopressin, that would not, the vasopressinase would be able to target that as well. However, ddavp is resistant to this vasopressinase, and so can be used to provide relief from the polyuria and the nocturia for the pregnant patient. So now let's talk about treatment. So we come back to that 80-year-old male who had Alzheimer's, and his labs show that the serum sodium is 175, and his blood pressure is 110/60, and he has some decreased skin turgor as well. So how would you treat him? Give him normal saline 100 ml per hour, normal saline plus the D5 water at 100 ml per hour, half normal saline at 100 ml per hour, or just D5 water at 100 ml per hour. So let's talk about how you correct someone with hypernatremia. So the key, again, just like hyponatremia, you don't want to rapidly correct because of in this case, it will cause cerebral edema, seizures, coma, and death. If you have someone with documented acute hypernatremia and is severely symptomatic, you can rapidly correct over the first few hours, but the goal should still be to correct them less than 10 to 12 in the first 24 hours. And for someone who is chronic hypernatremia, or you don't know how long their hypernatremia has been there, the goal is to correct them less than 10 over the first 24 hours. The data behind this is not very good, and this is extrapolated from the hyponatremia data as well and from animal data, but this is kind of the best goals of treatment that we have. So how do you calculate the free water deficit? So we'll use our patient to do that as well. So the current sodium minus 140 divided by 140 and multiplied by the total body water, which will be 0.5 into the weight. So in this patient who is at 175, so 175 minus 140, which is 35, divided by 140 and multiplied by 0.5 into the 60 kgs. So you get 35 by 140 into 30, which is 7.5 liters. So his current sodium is 175, and our goal is to correct less than 10 in a day. So we would plan to correct him over 4 days. So that would mean that our correction to replace the deficit would be 1.875. All these calculations do not take into account the current ongoing losses as well as the insensible losses that are going to happen every day. So you have to add that into your daily replacement as well. And so for this person, we would say that we want to correct over 4 days. And so 2.4 liters of extra free water would be a good start. And so we give D5 water at 100 ml per hour to give him 2.4 liters over the day. This patient is also volume depleted with hypotension as well as decreased skin turgor. So you want to replace the volume as well. And so as we've talked before, volume regulation and volume is a separate disorder, and water and hypernatremia are a separate disorder. So you can treat both, and you can give normal saline to fix the volume depletion and give D5 to fix the free water deficit that is there and the hypernatremia. And so in this situation, I would suggest giving normal saline and D5 together. You could also make the argument that and give half normal saline at 200 an hour, which would mean half being normal saline and half being D5 water. However, you have to be aware that as time progresses and as one of the disorders gets fixed either earlier or later, you would have to adjust it. And so you may then either have to change what you give or go to a D5 with NS or switch to one or the other, depending on the requirements of the patient over time. So now let's talk about the different entities that we have. So if someone has central diabetes insipidus, so the treatment would be ddavp. You can give it once or twice a day. And if you're giving it by nasal spray, you can give 5 to 20 micrograms over the day. And you start low and then titrate up based on the response of the patient. You can also give it as an oral dose. The oral dose absorption is much lower. And so you can start with a 0.05 milligram daily dose and then titrate up as needed. And the goal is to focus on resolution of nocturia, and they should still use thirst to guide their fluid intake. Most patients with central diabetes insipidus will have a habit of drinking lots of fluids, and many times once you start their treatment, they may continue their habit of high fluid intake. In the setting of now ddavp, they could get hyponatremic. So you would want them to uh, monitor their weights as well as recheck once you start them to ensure that they are not developing hyponatremia, and then adjust their fluid intake and ask them to monitor, take their fluid intake based on their thirst. Those with nephrogenic diabetes insipidus, the first thing is to try and see if there is any reversible cause like lithium that you can stop, or any chemo medicines which have caused, or any other medications which have caused the nephrogenic diabetes insipidus, which you can stop, and then that should help resolve it. You can also protein or salt restrict. We'll come to how it works in nephrogenic diabetes insipidus. This can also be done for patients with central diabetes insipidus. And then some volume loss, which causes decreased distal delivery by either thiazides, and you can combine with amiloride for potassium potassium sparing. And then if they have partial nephrogenic diabetes insipidus, you could, as a last ditch effort, also consider giving supraphysiological ddavp. So how does solute intake affect the urine output? This is something we've talked before for both hyponatremia as well as in the basic talk that we had. Low salt and low protein intake will lower the urine output in diabetes insipidus. So let's take a normal person whose normal solute intake is about 600 milliosmoles. If they drink about 1 liter, the body will adjust the urine osmolarity to 600 so that the urine volume is 1 liter. If they take 2 liters of fluid intake, the ADH secretion is regulated and the urine osmolarity goes down to 300 milliosmoles. And with this decrease in urine osmolarity, the urine volume will be now 2 liters. If they take 6 liters of fluid intake in a normal person, then the ADH shuts off, urine osmolarity goes down to 100, and the person excretes 6 liters and is in balance again. For someone with diabetes insipidus, their urine osmolarity is fixed. So if they take 600 milliosmoles, they will have to excrete 6 liters, and the thirst will dictate a 6 liter fluid intake. If now you decrease their solute intake to 300 milliosmoles, even though the urine osmolarity is still fixed at 100, they're going to only have a 3 liter fluid output, and so only a 3 liter intake will be needed. And so the decrease in solute intake by half will half their urine output, and so the nocturia and other polyuric symptoms that they have will be much better controlled. So now we'll come to another patient, which is something that we see very often and is a common cause of confrontation between the cardiologist and the nephrologist. A 60-year-old male who is 80 kgs and has heart failure with pedal edema and pulmonary edema and has massive volume overload of about 10 liters, gets intubated on arrival because of severe heart failure, and a Lasix or furosemide drip is started. The urine output is excellent, 150 ml per hour. The first day sodium was normal at 140. Next day is 146. The diuretics are continued. He has another 3.6 liters of output. And then on the second day, his serum sodium is now 153. So how are you going to proceed for him? Are you going to stop his diuretics? Stop his diuretics and give him free water? Continue the diuretics without giving him any free water? Continue diuretics and give free water at 150 ml per hour? So now this person has two separate disorders. One is volume overload and the second is hypernatremia. And as we've talked before, we have to treat them separately because the body treats them separately as well. So for the volume overload, you have to continue diuretics. This person is still in pulmonary edema, so you continue the diuretics. And you will need to give them free water. The free water will have to be one for the deficit, but also for the ongoing losses. The ongoing losses for this person, if he has a 3.6 liter output like he has had before, a diuretic or a Lasix urine output has a urine sodium of around half normal saline or 75 MEQs. So half of this is going to be free water and half of this is going to be electrolyte rich fluid. So the free water deficit from this 3.6 liters is going to be about 1.8 liters. So plus the 500 ml of insensible losses, plus if you want to correct over 3 days, as this is now chronic hypernatremia over the last two days. So 1/3 of this deficit and is 1.2 liters. So the total fluid that we should give free water would be 3.5 liters, which would be 150 ml per hour. And the key concern that the cardiologists have is that when we give this amount of D5 water, the patient will get a lot of volume and will not be negative, and this will hamper the pulmonary edema. The D5 water, like all water, is going to distribute 2/3 into the intracellular compartment and only 1/3 in the extracellular compartment. And so as we continue our diuretics, the person's extracellular compartment, interstitial compartment, the edema is going to be coming down, and the free water or the D5 that we are going to give is going to go predominantly into the intracellular compartment. Even if the input output matches, the person is actually getting extracellular fluid volume negative. So my take home messages from the talk today is that hypernatremia only happens when a person is unable to respond to their thirst, and so is usually some kind of either infant or an old person or some kind of deficit that doesn't allow them to respond to their thirst. To evaluate hypernatremia, focus on the urine osmolarity and then the response to ddavp. For polyuria, evaluate with the urine volume and the urine solute and the urine osmolarity to assess whether it is a water diuresis and solute diuresis, and then proceed based on that. Treatment is free water, whether by D5 or through the oral or nasogastric tube for increasing water intake. And in case someone has volume overload and hypernatremia, give both diuretics and free water to treat both those entities. Thank you, and I'll take any questions.
Thank you very much, Ajay. That was again, as expected, a very assured presentation. You addressed a number of questions which are important, especially while nephrologists are called on consultations in cardiac ward. The last issue that you addressed is perhaps one of the most frequent situations that nephrology trainees encounter in cardiology wards, that patients have two separate disorders, and you made this point very clearly that different disorders need to be treated differently, disorders of volume as well as disorders of water metabolism. So with that, as usual, the talk is open for questions. So please feel free to go ahead, ask your questions. You can ask your questions in the chat pane. You can ask your questions by raising your hand, in which case I will unmute you and you can ask your question directly. So do go ahead. Looks like your previous talks have really helped clarify the concepts. So it looks like the people who are attending these webinars repeatedly are have got the hang of the particular topic. So I think one of the points that you made is that development of hypernatremia requires the thirst response to be blunted. That's really critical. And so if this is something something that we should always look for, that if the person is fully conscious, then it is highly unlikely, and has access to water, of course. I mean, if a conscious person needs to have access to water, highly unlikely that the person will develop hypernatremia. So one of the go ahead, Ajay.
No, so I think that is kind of the key point in hypernatremia, is that a conscious person with access to water will not develop hypernatremia, and that's proven by all the patients with central diabetes insipidus who will drink 10 liters but not develop hypernatremia till they come to the hospital and we make them NPO, and then they will get hypernatremia.
Right. So we have a question from Dr. Venkatesh Rajkumar. Dr. Venkatesh, please go ahead and ask your question.
Yeah, thank you, sir. That was a lucid presentation, Dr. Ajay. So, this regarding you heard about hypernatremia in the case of volume depletion as well. So, you are advising for both free water as well as say normal saline. So, I'm not very sure like if that is the way I do it here regularly. My question is, what is the likely consequence we are going to treat somebody with hypernatremia and volume depletion at the same time only with free water?
So if someone has actual volume depletion and you give only free water, that volume depletion will not be fixed, because the water that you give is going to go, as we've discussed before, 2/3 of it is going to go inside the cell and it will increase the intracellular compartment. It will not increase the extracellular fluid or the intravascular compartment. Only 1/3 will be in that compartment. And so if you have someone who has volume depleted, then you will need to give them some normal saline. You could do it by a half normal saline where you combine the free water that you're giving with the D5 and the normal saline, and instead of giving 100 ml of each, you could give 200 ml of half normal saline and achieve the same impact on both fronts. But then you would have to assess each part separately going forward and then adjust it, and you may have to go to a quarter normal or you may have to go to 3/4 normal depending on what the situation is for that patient. And so sometimes it is easier to keep the two compartments separate, which the body is doing every day anyways, and treat the volume compartment and the hypernatremia with D5 and the volume depletion with NS, and then you can stop whenever you feel one of those issues has been resolved.
So thanks, Ajay. If I might extend that point and perhaps at risk of being repetitive, Venkatesh, if a person is truly hypovolemic, and if you're trying to correct that hypovolemia by giving some kind of fluid, then you need that fluid to stick within the intravascular space. And it will stick within the intravascular space only if it is, the fluid is not free water. If it is free water, 2/3 of that will go into intracellular space, and so it will redistribute in that way. And I think that the second point that Ajay made was just like we use fixed dose combinations of certain drug, and if you want to adjust the dose of one of the two, or three drugs that are there in fixed dose combination, it will be somewhat harder than if you are using these drugs independently, and then you could adjust the doses, independent of each other. So that is a very, very useful concept for us to remember. I think there is a question from Dr. Sumantra. So there are several questions. Let me try to get to the question pane. While I do that, I think there is Dr. Gopesh Modi has raised his hand. So Dr. Gopesh, please go ahead.
Hi Ajay, and good evening, Vivek. It was nice listening to the talk. The question I have is, osmolality measurement is not available at most places. Would you, for the sake of clarity, suggest adaptations or alternatives to use your paradigms?
So the way to do it is specific gravity would work for the water deprivation test. So that might be, so in the slides that I had, there is specific gravity. So let me come back to that slide as well. So there is specific gravity in there as well. So on the leftmost column is urine specific gravity. So you could use that as a surrogate for urine osmolarity. The problem is that if plasma osmolarity, you could then use the serum sodium and just multiply by 2 and use that as a surrogate. because someone shouldn't have any other osmolar gaps or something at the same time as this. So you could kind of just multiply by 2 for the plasma osmolarity and get close to 145 and above, and that will give you 290 or 295. And then the urine or specific gravity would be another way for the water deprivation test. And then you can combine this with urine volume. So I have not put that for time's sake in there. I have it afterwards somewhere. So there is a urine volume. Let me get that. So there are urine volume parameters that you can track with the water deprivation test. So you can track that and see the urine volume in ml per minute as you track. And those with complete nephrogenic diabetes insipidus will have a straight line and not respond when you give ddavp. Those with complete central DI will respond with a drop in their urine volume and urine rate that they're excreting, and then the normal and the partial will be in the middle. So you can use that, and then instead of plasma osmolarity, you can double the serum sodium, and that might be a reasonable way when you don't have osmolarity.
Thanks, Ajay. So we have questions from, or maybe some comments from Dr. Krishna Sahu related to the previous question. So Dr. Sahu has 2 points. One is that he says that regarding the 80-year-old person who you mentioned with the serum sodium of 175, he agrees with everything except for the addition of normal saline for fluid deficit. He says that it will make your calculations of sodium excess or water deficit go haywire.
So the calculations for whether it is sodium deficit or free water deficit, the sodium deficit calculations are when you're trying to assess someone for hyponatremia. For hypernatremia, it is water deficit calculations. All of those are estimates. None of them are written in stone. And the key thing for them is that you start with an estimate, you start with your treatment, and then you follow how they respond, whether it is by their serum sodiums or whether it is by their volume assessment. And that combination of things is going to need an ongoing assessment, and then you're going to need to adjust it based on how they're responding. So I don't think that it is something that I put my hat on and that I've picked a number and so I have to stick with it for the rest of the 4 days. So I would pick what I think is my best assessment for both their volume and their free water. I start them on a treatment and then I reassess them every 3 hours or 6 hours or 12 hours or 24 hours, and then adjust based on how they've responded in the time and what my current examination and evaluation of the patient is. And then we go from there.
That's a good explanation, that you are setting a you are setting a target, but that target can move from time to time depending on what the situation is. And his second point is that he says that if the serum sodium at 175, you don't need to give add normal saline for free water to stay intravascular if the person is hypovolemic. So he says that even D5 water will stay intravascular.
It won't, because what is intracellular, the intracellular osmolarity is going to be the same as the intravascular compartment. And so the water will distribute 2/3 inside the cell and 1/3 in the extracellular compartment. So the osmolarity, water moves freely between the cell and between the vasculature. So the volume and water distribution will remain the same. And so 2/3 of whatever you give when you give D5 is going to go inside the cell, and only 1/3 will remain in the extracellular compartment. So if you really want to enhance the volume and you want to correct someone's volume deficit, as Dr. Jha had also mentioned, you need something that sticks in the blood vessel and sticks in the interstitial compartment, and that will have to be NS.
So as Ajay, as you said, I think the key point here is to understand that the determinant of serum sodium is osmolality and nothing else. And osmolality is going to be the same inside the cell as well as outside the cell in this situation. And therefore, when water goes in, and if it doesn't have sodium with it, it will fix the osmolality and go inside the cell too. I think Dr. Kher, did you want to say something?
Yeah,
Dr. Vijay
yeah,
Kher?
yeah. I thought that, see, in one of the lectures, earlier lectures, which Ajay had talked about the relationship of osmolality with the volume, and this was that when you have, see, body in the early stages wants to maintain osmolality, and when volume and osmolality are at contradiction to each other, and that happens only when volume depletion occurs to more than 10% of the body weight. That means when hypotension threatens the body, that is the time when ADH revs up because of the volume depletion. And then body gives up osmolality and takes care of the volume, because at that point of time, body has to save the perfusion to the organs. And that's how body maintains volume relationship along with osmolality relationship. And that's exactly what we need to do when we are treating our patients. If there is volume depletion and we need to correct osmolality, I think the first thing that we need to do is to correct the volume, because that is going to threaten the perfusion to the kidneys. And that's what one should do clinically also, and that's what Ajay also said. And these are contradictory things which happen sometimes when you are treating patients. You're called especially to say neurosurgery or to cardiovascular department or cardiology department, and that's where you will find these things that should you give water or should you give continued diuretics, and those kinds of contradictions come in. But I think the principles which Ajay laid down, and which are especially important because that's the way body treats and keeps the hemodynamics as well as the acid base and the electrolyte balance in order. And I think those are the principles which, if understood well, then you can practice them exactly the way they have been explained.
I think Ajay has a slide to make this point.
Yes,
Ajay,
yes, that's the
So I,
one I was talking about.
yeah, I
Yes,
just
Ajay, you
pulled
can
up
highlight that.
the slide from the previous talk. So this in the empty circles is the ADH. So on the on the y-axis is the ADH, and on the x-axis is the percent change. So if you look at osmolarity, it is a very tight linear line. As you go up even 1%, your ADH goes up and down very tightly. If you look at with volume loss for the first 7 to 10%, ADH is not increased. And during this time, the body will rev up renin-angioaldosterone system, the carotid sinus will impact the sympathetics, and the ANP will shut down. And if even with all of that, the body cannot maintain its volume and it continues to lose volume beyond that 7 to 10%, then ADH revs up in an exponential fashion as a last ditch effort to save the organism. And so that is where the volume is. And so which is why if you are in this range and your effective volume is severely depleted for whatever reason, whether it is true volume loss or whether it is effective, you want to fix that first and then adjust for the osmolarity. But if there are concomitant two issues, then you can treat concomitantly as well, because you have two different fluids or two different solutions that you can give simultaneously, or you can diurese someone if they're volume overloaded and give them D5 at the same time as well, and fix both the issues together.
Yeah, that's an important point, because many people cannot conceptually handle this idea that you can continue to diurese someone and give free water at the same time. But that's something, it sounds not normal, but then as nephrologists we have to be able to understand and convince our colleagues that that is the right thing to do in these situations. So
Vivek, another comment I wanted to make was what Gopesh Modi was making about it. And I think it's important for nephrologists to ensure actually that in their practice they must fix the administrators and tell them that there is a need for osmometer in their hospitals and all that. And I think it's important because osmometer would help a routine nephrologist to be able to manage electrolyte imbalances and water deficits. Whereas you require a real good expert without the osmometer to fix specific gravities and all those kind of things. And if you have mixed kind of problems, then you are unable to do this correctly. So I think having an osmometer is extremely important for day-to-day practices of water and electrolyte imbalance. And I think as nephrologists, we must emphasize the need for this.
Yeah, in fact, osmometer is more useful in a hospital which has large cardiology and neurosurgery practice rather than just a nephrology practice, because in a pure nephrology practice, you will need to use an osmometer only rarely.
Yes, I agree. I agree with that.
Yeah, if a hospital runs a cardiology or neurosurgery service, the chances are they will need to use an osmometer more frequently because these are the kind of problems who have these disorders. So we'll go back to the list of questions. Dr. Subal Pradhan wants to know, how do you treat a post-surgical central diabetes insipidus, such as post-craniopharyngioma surgery, something like that?
So patients with that can have a time course, and I didn't go into that for time constraints, but I have a slide on that also, that they can start with something like this, where they have a surgery, and after the surgery, so this just to orient people, on the y-axis is volume, and then there is also urine output as well as water intake, and then on the x-axis is the days before and after surgery. And so the volume and the urine output initially is stable with water intake, and then post-op they can have a drop in their urine osmolarity as there is no ADH being produced, and they go into a diabetes insipidus, and then they have a release of ADH for a few days, and then they can go back into their diabetes insipidus. So during this time, this part can also be due to diabetes insipidus, but it can also be due to the mannitol and osmotic diuresis that is being done for treatment or for prophylaxis of cerebral edema also. So this is going to be an ongoing up and down. So it will be something that you're going to have to assess what their current status is, and then adjust the water intake as well as monitor their serum sodiums and adjust the fluid intake based on that. So this is going to be something that you're going to need to monitor closely, see what their stage is, as well as then assess if they're staying in it or whether they're fluctuating from that.
Okay, thank you. Dr. Bhupesh Modi's question has already been answered. So we have a question from Dr. Sumantra Raut, who asks, can we evaluate for etiology of hypernatremia by urine osm if the patient is on IV fluids?
So if they are hypernatremic, you can still evaluate them. So as long as they're hypernatremic, meaning their urine, their plasma osmolarity is above 295, which means their and their serum sodium is more than 145, which will get you 295 to a plasma osmolarity of 295. You can assess the urine osmolarity, and the kidney, the brain should put out ADH, the kidney should respond to that ADH, and the urine osmolarity should be more than 600. If it is not more than 600 at that time, then you can give them ddavp and see their response. So as long as they're currently hypernatremic, and not that they were hypernatremic 3 days back or 4 days back and 5 days back and are currently not hypernatremic, then you will have to do a full water deprivation, or do it once they're stable, do a full evaluation at that point. But if they're currently hypernatremic, you can evaluate them with the urine osmolarity, and then based on their situation, give them ddavp.
Thanks. The next question is from Dr. Dhanin Putiotil, who wants to know, do we need to include extra volume in body weight for calculation of water deficit? So I think a simple answer to this question is that you did mention that this target is a rough target, it's not a precise target. So you go with what weight you have, and then you can adjust it as you go along. Is that something you'll agree with?
Fair, or the usual other guidelines suggest that you be a little more conservative in what you target. So instead of putting 0.5 of weight, you can put 0.4 of weight and be a little more conservative so you don't overcorrect, because undercorrection, as long as you're still correcting, most problems are from over or rapid correction. As long as you're correcting and you're moving their sodiums better, whether it is hyponatremia or hypernatremia, as long as you're moving in the right direction, you're safe. So you don't want to overcorrect. So you can target a 0.4 by weight rather than a 0.5 by weight and make your calculations from that.
Right. So the next question again is for Dr. Sumantra Raut. How does thiazide act in NDI?
So as I had said, the thiazides cause volume depletion. And with that volume depletion, what will happen is that there will be decreased distal delivery. With this decreased distal delivery, there are some paracellular non-aquaporin mediated water absorption as well. And with that, because the volume and the distal delivery is low, that small amount of water that is being absorbed will raise the osmolarity and decrease the polyuria that this person is having. So if someone's urine osmolarity is 100, you increase their urine osmolarity 200 to 200, their volume goes down by half. And their main concern with the diabetes insipidus is polyuria, and especially nocturia. So if you can cut down their polyuria and nocturia by half, that would make a significant impact in their lifestyle and quality of life. And so thiazide should work through that mechanism by causing that volume loss, so that there is one of this paracellular mechanism. The second is, most patients with nephrogenic diabetes insipidus are partial nephrogenic diabetes insipidus. And as you cause volume loss, you're going to cause ADH to go up from volume mechanisms rather than osmolarity mechanisms. And so that ADH that revs up from volume, because they are partial nephrogenic, they will respond to it with some amount of response, and that will help their polyuria as well.
So there are a couple of questions from Dr. Shagufta Tarannum, who wants to know what are the indications of dialysis in hypernatremia and which mode of dialysis is preferred.
Okay, so indications for dialysis would be where someone has severe renal failure in addition to symptomatic hypernatremia. Because if it is asymptomatic, you can give plain water and it will slowly correct. So if someone is severely symptomatic and has renal failure, where you have other indications as well, then you could do it. The problem is mostly going to be controlling the rate at which this hypernatremia corrects. Because someone who is severely hypernatremic, your dialysis sodium will only go up so much. It's not going to be, if someone's 170 or 180, you're not going to be able to get your dialysate sodium to within 10 of that. So correcting them is actually going to be riskier with dialysis rather than just with plain water. So I would say I would try and not dialyze them unless there are some other indications for dialysis in addition to the hypernatremia. If it is just hypernatremia, that is the indication, I would stick to giving them plain water and controlling them that way. But if there are other indications, the way to do it would be a slow dialysis, try and get the sodium as high as possible. You could also consider giving them 3% on the side with some math and calculation to try and get the sodium that you're delivering, which is higher than the 145, 150 that you can max out on the dialysis machine, and do it that way.
So I think a prudent answer would be don't dialyze unless you absolutely have to.
Absolutely.
The treatment of hypernatremia is not by dialysis. And so usually the indication for dialysis will be a non-hypernatremic condition, because even if you have to do it, push the dialysate sodium up as high as your machine permits and measure repeatedly. I guess these would be a few things. Even then, you are not really sure about whether or not you have been able to avert any disaster. So then One more question we have is from Dr. Rajiv Sinha. How useful is copeptin in differentiating central and nephrogenic diabetes insipidus?
So ddavp is usually what is used. I can't say I've looked into copeptin and can answer that per se, but ddavp is readily available, so I would do that. If there is confusion, usually if the water deprivation test is equivocal, then the usual recommendation is to do ADH testing and ADH testing during a water deprivation test to help guide the diagnosis between partial central DI or primary polydipsia or partial nephrogenic DI.
Right. So we have the gold standard, which is water deprivation. So there should be a special reason to look for copeptin. It has been suggested as a surrogate marker, but then I don't think it is an established diagnostic test in this situation. Dr. Snehal Gaikwad asks, what would the role of acute peritoneal dialysis in hypernatremia? I think there also you have more or less the same situation. The fluxes are not as rapid, but peritoneal dialysis is not going to correct hypernatremia. So let's be clear that we are not using these modalities to correct hypernatremia. If you have hypernatremia which you want to correct, unless there is something else which is wrong with this patient, you can give them free water anyway, unless there's something else, some other indication which forces them to receive dialysis. Dr. Shagufta asks again, what is the weight which you should use for calculation in a malnourished person? Should it be an actual body weight or ideal body weight?
So again, as we've talked before, I would use the current body weight and use either 0.4 or 0.5. These are estimates. You start with whatever your estimate is, and then you follow how they respond for both hypo and hypernatremia.
So in this situation, you must use the current body weight because the water is distributed in his current body. It is not distributed in some ideal body. So even if you are able to correct his water deficit, it will still remain within his current body. So there is no reason to think of using the ideal body weight here. Then the last question we have again from Dr. Sumantra Raut, role of thiazide versus NSAID in nephrogenic diabetes insipidus.
So both have been used. We talked about how thiazide works and why it works in nephrogenic DI. NSAIDs have been used as well. Being a nephrologist, anytime someone says you have to give NSAIDs daily for someone who has nephrogenic diabetes insipidus, my heart rate goes up a little. So I would not be inclined to use NSAIDs on a daily basis for someone with any kind of disease. So NSAIDs do work for free water deficits and can help with nephrogenic diabetes insipidus. So it can be used.
All right. It looks like we might have run out of questions. I didn't think that was possible, but it does look like we have run out of questions now. So once again, thanks everyone for participating in this webinar, and thank you for all your questions. And thanks Ajay for this wonderful presentation.
Thank you, Dr. Jha.
All right, bye-bye everyone.